Good afternoon. Welcome to Wonderful Wednesday. Step 3, the venous story, looking at CVP and wedge pressure and understanding what they should look like and what the waveforms are, as well as the basic digits. The digits are not nearly as important as the waveform analysis. So you see down here, I have YouTube. I have a YouTube channel, and on that YouTube channel, I post all of the virtual sessions. Those are called critical care snippets. I have a critical care course plus a six series quick look at critical care. And currently there's around 58 videos. And after this weekend, there will be around 75. I'm also going to be posting at least the component of CCRN review that I do. And that would be cardiac, pulmonary, endocrine, renal, multisystem, and a couple of other things. So feel free. It's totally free. If you subscribe to the channel, you'll get notified when there are new additions. And I try to add additions in groups of around 5, so you don't get notified too much. No cost, no problem. Just if you wish to see anything that I've done or that you've missed or that you'd like to see again, please feel free to log on to YouTube, Barbara McLean Critical Care. All right, my friends. So really phenomenally important to remember that when we're talking about vascular monitoring, meaning monitoring a chamber that has blood in it, there are 3 basic types, right? First of all, the venous pressure, which is our most common. And we're looking at systemic venous return to the right heart. We call that the CVP. And pulmonary venous return to the left heart. And that's called pulmonary capillary wedge or pulmonary arterial occlusion pressure. So that's down here, number 3, really gorgeous, because what you're looking at here is just some fluctuations in the atrial pressure that will reflect in our venous monitoring. Number 2 is arterial pressure. And arterial pressure, of course, something we're all familiar with, really, no matter where you were, because at least you've had systemic arterial lines, and sometimes you have pulmonary arterial lines, but you're monitoring arterial pressure, which consists of a upstroke to systole, a fall down to the closure of the valve that separates the ventricle from the artery. So for the left ventricle, that'll be the aortic valve. And for the right ventricle, that will be the pulmonic valve. That inscribes what we call the dicrotic notch. So you have a big ventricle ejecting into an artery, and then the valve closes, and you have a little bit of a flux up in the pressure there, because now I'm looking at the arterial pressure, and then ultimately down to diastole. So systole, dicrotic notch, diastole. And then another concept, which you only monitor when you are inserting a PA catheter, or inadvertently if you have a PA catheter, unless you work in the cath lab, in which case you can monitor left ventricular pressure. So in the ICU, when you're placing a PA catheter, you can monitor right ventricular pressure as the catheter passes through the right ventricle, or you might be monitoring it inadvertently. So not on purpose, but maybe the catheter tip is in the RV and you're monitoring ventricular pressure. Now, ventricular pressure is very similar to atrial pressure in that it has an upstroke to systole. But that's where the similarities end. Because what ends up happening is in ventricular pressure, you're not looking at a pressure change between 2 chambers. You're only looking at the ventricular pressure, and that ventricular pressure rapidly drops to diastole, no dicrotic notch, and a much lower diastole than you see in the pulmonary artery. Okay, so remember, everyone, when you've got an A line, you can always look at arterial pressure. Your A line typically for all of you is in the systemic artery, the radial artery, the brachial artery, the femoral artery. That's systemic arterial pressure. In order to monitor the arterial pressure in the pulmonary vessel, you must have a pulmonary artery catheter. And that's why we've spent a lot of time talking about the PA catheter and what it really means to us. So I want to just separate arterial pressure from venous pressure in the way in which I think about it and how I look at it when I come to the bedside. Typically, Now, what I'm showing you here is I've just used a different color, or red and blue. That's not actually telling you anything about oxygenated or deoxygenated. I just used two different colors here. Everywhere else, red and blue are going to be deoxygenated blue and reoxygenated red, but not in this view. So I'm looking at the arteries and I'm going to evaluate ejection by the systolic pressure. So systolic pressure in the systemic artery reflects LV ejection. Systolic pressure in the pulmonary artery reflects RV ejection, and they are not the same. Then we talk about the tone of the artery, and that is evaluated by the diastolic pressure. So diastolic pressure in the systemic artery represents the arterial tone. It's also affected by the volume and the ejection, but it truly is a measure of arterial tone. And in the pulmonary artery, the diastolic pressure is a measure of the pulmonary arterial tone. Okay. Now, diastolic pressure plays a really important component in the development and the evaluation of mean arterial pressure. That is, that diastolic time lasts about twice as long as systolic time. So diastolic pressure becomes 2/3 of the mean arterial pressure, whereas systolic pressure is 1/3 of the mean arterial pressure. So most of the time when our mean arterial pressure is low, what we do is try to enhance tone by giving vasopressors, enhancing the tone, raising the diastolic pressure, which in turn should raise your mean arterial pressure. Now, what's really important to remember about the arteries is they are thick and muscular, and they have multiple layers of elastic fibers. What that means is they can actually constrict or dilate quite aggressively, and typically there's fairly high pressure in them. So remember, blood is oxygenated in the systemic arterial flow, and it's relatively deoxygenated in the pulmonary arterial flow. And we'll look a little more at that in a moment. Now, if I move over to the venous pressure, you're going to see there's quite a bit of difference here, right? Venous pressure, we're going to use venous pressure to tell us about the pressure, not the pressure that you give, the pressure that is generated when volume fills the ventricles. Okay, now that's really important, so I'm going to say it again. When we look at venous pressure, so in our practice, we use CVP to reflect the right heart, and we use wedge pressure to reflect wedge pressure, or PA diastolic pressure to reflect the left heart. These are venous pressures. Venous pressures reflect the volume that fills the right heart and the compliance of the right heart, of the whole right heart, the right atria, the right ventricle, and included in that would be the tricuspid valve. So CVP reflects right heart filling. Wedge pressure reflects left heart filling, okay? And ultimately, we're going to say CVP tells us about the RV and wedge pressure tells us about the LV. But these are venous pressures, so it's the column of venous blood that projects towards the ventricle, and depending on, most important, the compliance of the ventricle, and next important, not quite as much, is the amount of volume. Now, if my ventricle is stiff and narrow, a lot of pressure will be generated when we're trying to put volume in there because the ventricle is non-compliant. So one thing I want to say here, I'll mention it again probably multiple times, is just to remember, CVP is not a volume number. When you ask for a central venous catheter, you ask your doctor to place it because you want to look at the right heart. They'll say, well, you know, CVP is not a volume indicator. Yes, of course. Thank you so much for telling me. And I'm so happy that you know that. CVP is about compliance. In a normal right heart, I could give you 5 liters of volume and your CVP wouldn't change. But if you have a non-compliant right heart, that might be a reflection of failure of the left heart or just failure of the right heart. If the right heart is non-compliant, when I give a little volume, CVP will go up extraordinarily high. So I'm going to use this to actually help me understand the compliance of filling the ventricle. Does the ventricle accept the volume you gave it and say, ah? Or does the ventricle not accept the volume that you're trying to give it and it says, ah? Okay, because you can't fill it. It's not compliant. So now you got a column of blood in the vein. It's static. It engorges your veins, and then the fluid escapes. Fluid escapes into the pulmonary interstitium if it's left heart, and into the systemic interstitium if it's right heart. Pretty darn straightforward, really, if we just remember to look at it the right way. Venous pressure is about the volume filling a chamber. And if the chamber is non-compliant, the volume will be static in the veins and engorge the veins and creep out into the interstitium. That's like one of the most valuable things I can say to you. It's so meaningful in terms of how we look at pressure monitoring. So depending on where you work, you're working in the ECC, you're going to do a lot of CVP, you do a lot of arterial pressure monitoring. Your doc puts in a central line. You don't hook that line up to pressure tubing and hemodynamic monitoring. Quite honestly, I'm just going to say, you're giving your patient half of what they could have because you're not actually evolving the full picture of your patient's hemodynamics. If you've got a CVP catheter, you should always hook it to pressure tubing, to a transducer, to a fluid bag that's under 300 millimeters of mercury so that you can continuously monitor venous pressure. Okay, so that's for your CVP. You know to do it for the A line, you should also be doing it for the central line because that's going to give you an abundant amount of information. Okay, now veins are very thin walls. They don't have much muscle. They don't really constrict and dilate like the arteries do. It's always happening to maintain your pressure. The veins really are thin walls. They have a very wide lumen. And in your venous pressure, so that means CVP, wedge, these are not pulsatile pressures. It's not like systole and diastole. It's small fluctuations that reflect pressure changes in the atria, because remember, you're looking towards the atria. You're not in the ventricle. You may not be in the atria. You're looking towards the atria. So what you're going to see are small pressure fluctuations that tell you about three basic things that happen. The atria contracts, the valve between the atrium and ventricle closes, and the valve bulges upwards. The atria contracts, the valve closes, and when the ventricle is ejecting, the valve bulges upwards. Now, those people who are CVICU nurses already say, well, here's a problem with that, because what about if the valve is regurgitating? Phenomenal. That's really important when we're talking about venous pressure. So want to remind you that you have an expectation that you have fluctuating waves, and that those fluctuating waves are small. They're not phasic, they're not large, and they're about at equal height to each other. That's really important. And we're going to look at those waves in a few seconds, okay? Now, just remember that venous blood is returning to the heart. So systemic veins return relatively deoxygenated blood to the right heart. Pulmonary veins are post-alveolar blood exchange. So pulmonary veins are returning reoxygenated blood to the left heart. So that's always really important to remember. Now, what I've done here, and this is a cartoon that actually an artist helped draw based on what my vision was, and it didn't quite work out the way I wanted to, but I think it's somewhat explanatory. So your left ventricle ejects oxygenated blood into the artery. The arteries divide into arterioles and then into capillaries, where oxygen is delivered to the cell and carbon dioxide is picked up, or really is hydrogen ion picked up from the cell. So oxygen is transported to the cell. CO2 and hydrogen ion are transported to the lung. Okay, so that's the shift between oxygenated and deoxygenated blood. Now that left ventricle is ejecting into the systemic artery. So I'm going to look at systemic arterial systolic pressure to reflect LV ejection and LV stroke volume. Fantastic. Okay. And in the artery itself, I'm going to look at that systemic arterial systolic pressure to reflect the LV function. I'm going to look at systemic arterial diastolic pressure to reflect the vascular tone. And then a calculation is going to occur, and there are a lot of different ones, like systole plus 2 times diastole divided by 3, diastole plus 1/3 pulse pressure, which is also a fantastic way of looking at mean. So It doesn't really matter to me what calculation you do. And by the way, you never do a calculation because it's projected on your monitor. So you don't, most of you don't ever do a calculation, or maybe don't even know the calculation. Okay, no one cares. Let your monitor do it. But I want you to remember that mean is most affected by diastolic pressure and the time of diastole. That mean pressure is really what's driving the blood flow through the capillaries and ultimately mean pressure, ultimately pushing that blood back to the right atria. The right atria fills with that blood and it empties the blood. The tricuspid valve opens and closes, and the right ventricle fills. When the RA is emptying, the RV fills. And when the RV is ejecting, the RA is filling. It's such a phenomenal system, and it works so beautifully. Okay. So this is LV pressure. You will never see LV pressure except in the cath lab. Never, never, never. Nothing you can do with any catheter except, your Impella. So other than the Impella device, you will never see LV pressure because you never put a catheter in the LV except when you do the Impella. Okay. So LV pressure, high systole, low diastole, ejecting blood into the pulmonary artery. Now the systole is basically and virtually the same. It's the diastole that changes because you went from one big chamber into a much smaller and longer chamber, and that's the artery. So diastolic pressure changes radically between these two. So now I'm out in the systemic artery, and this dark red line here, that's showing you the mean. The mean pressure is what continuously drives that blood flow, push, 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 into the capillaries where gas exchange takes place. And ultimately that mean pressure, that is what you're looking at on your monitor with arterial pressure, that is the pressure that is required to push that blood all the way back to the right atria. So your left ventricle has to overcome all the resistance of the arteries in order to move blood back to the right atria. So that's the second component of the resistance. First component is the artery. Second component is the right atria, or CVP. Okay, so just want to remind you, most important is to remember, if I have an invasive arterial line, I'm going to use systemic arterial blood pressure, systolic, to reflect what my RV is doing. So when you get a patient at the ECC with a systolic pressure of 200, your left ventricle is having to work so hard to move blood into that artery, which is constricted. That's why we like to vasodilate those patients so that the LV doesn't have to work so hard. Now, the LV, if it's always working against that resistance, it's going to hypertrophy. And when it hypertrophies, it's going to be harder to, guess what? Fill. Okay, that's really important. Okay, so LV reflection in the arterial blood pressure systolic. And for people who work in the ICU with an A line, you're talking about also stroke volume monitoring. Okay, so LV ejects into the systemic artery. That mean pressure that's derived must be able to overcome the resistance of the right atria. And we're measuring that resistance in the right atria as CVP, which is a reflection of the RV. So CVP is RV reflected and directly monitoring the right atria. The right atria is always a reflection of the right ventricle. Most people don't care about the atria, although they should. We really care about the ventricle, but the RA is a direct conduit into the RV. So we're going to use CVP to tell us about ultimately RV filling. That's why venous pressure is called filling pressure. Okay, now the right heart works in the exact same way, except it's mobilizing blood flow against a very low resistance circuit. So the right ventricle ejects, and we call that the right ventricular stroke volume. And we're going to evaluate that with pulmonary arterial systolic pressure. Because remember, we don't have a catheter in the RV. We shouldn't. But what we have is a catheter in the pulmonary artery. So systolic pressure in the pulmonary artery is reflecting RV ejection. And then we talk about the pulmonary arterial pressures and tone. And you'll notice here, these are both blue. That's because this is deoxygenated blood. This is mixed blood, mixed in the right atrium, mixed in the right ventricle, and ejected up into the pulmonary artery. So that's why it's blue. So PA systolic, remember, reflects RV ejection. PA diastolic reflects pulmonary arterial tone. And ultimately, the diastolic pressure here in a very short connection is also about LV filling in an indirect way. Okay, and then of course your calculated mean, and the mean is what continuously drives blood flow past your gas units, your alveoli, so that you can download CO2 into the alveoli and upload oxygen into the blood and promote gas exchange. Fantastic. Such a fabulous thing. And the blood changes from being deoxygenated to reoxygenated. That reoxygenated blood is going to go ultimately in the pulmonary venule, the pulmonary vein, to the left atria, and ultimately to the left ventricle. Okay. So we're going to use pulmonary capillary wedge pressure. That's what we talk about, or PA diastolic pressure. And that's what that was, really should have been PAD. I kind of wrote this little term right before we got on. I might not have saved it or did a little something wrong, but wedge pressure and PAD. Okay. That's actually telling me about the pressure column that moves past the capillary to the pulmonary venule, to the pulmonary vein, and ultimately the left atria, and the left atria fills the left ventricle. So left atria fills and empties, LV fills when the LA is emptying, the LV is filling, and the LV ejects. Okay, so really critically important. But I want you to hear the difference between the two. Okay, CVP directly looks at right atrial pressure, which directly reflects right ventricular pressure. CVP, 2 spaces away from the right ventricle. It's in the central vein or it's in the right atria, then it's only 1 space removed from the right ventricle. Wedge pressure, left ventricle, left atria, pulmonary veins, pulmonary venules, and the pressure here measured in the pulmonary capillary, 5 spaces removed. If you say you're not doing wedge pressure, and a lot of us aren't inflating balloons on PA catheters, we're using PA diastolic, that's 6 places removed from the left ventricle. So make sure you appreciate CVP is a direct measure of right ventricular filling, wedge pressure and PAD, and really we're talking about wedge pressure, but most of us don't use wedge, so we're going to use PAD. So I'm just going to always say wedge, but remember, you're going to use PAD to reflect the wedge. Wedge pressure, 5 compartments away from the left ventricle, which means it doesn't have as much value as the direct measurements. Okay, so from my PA, my mean PA is what's going to drive that blood flow dynamic from the pre-alveoli to the post-alveoli, where gas exchange has taken place, and ultimately to the filling of the left atria. So again, PA pressure actually is the first measure of the resistance in the arteries on the pulmonary bed, and at the end is the pulmonary venous pressure. Pulmonary arterial pressure must be high enough to overcome pulmonary venous pressure. Well, in normal circumstance, that's not a problem. But when you have heart failure, your pulmonary venous pressure goes up because you can't fill the left ventricle, or because you can't empty the left ventricle. So pulmonary venous pressure goes up, which means pulmonary arterial pressure must go up, which means the right heart's going to work harder, but less blood is going to get oxygenated. That's what happens when we have heart failure. It's such an incredible, I mean, how could things be so incredible? So in venous pressures, so again, CVP for the right heart, wedge pressure for the left heart, there are multiple components that cause those fluctuations in our venous pressure measurement. I can go into the ECC right now. Anybody who's got CVP, who's hooked up to pressure monitoring, I can put them up on the screen. I can say, oh, look, you have a normal A wave, you have a normal V wave. I don't have a C wave because maybe their valve is stenotic, right? But I can look at that and differentiate the components. So very important to remember, the A wave, I love this part, the A wave is the pressure increase in the atria, either right atria or left atria, it just depends on what you're monitoring, right atria or left atria. The A wave is the increased pressure in the atria and atrial contraction. How lovely. Atrial contraction causes an A wave. The C wave is a slight shift in the pressure, like with the dicrotic notch, when The valve closes that separates the ventricle from the atria. So that would be your tricuspid valve on the right or your mitral valve on the left. But that valve's got to close. If it's stenotic, it never opened and it doesn't close, so you won't have a C wave. Okay. I'm not going to talk about X descent and Y descent right now. I just want to talk about A wave and C wave. Okay, so C wave, even though it says here isovolumetric ventricular contraction, I want you to think about it. C wave, valve closed. And then V wave, when your ventricle is ejecting, remember your atria is filling, ventricle is ejecting, atria is filling, the valve, tricuspid on the right, mitral on the left, the valve bulges upwards into the atrium, making the atria smaller because the ventricle is generating extraordinary pressure because the chamber is getting smaller, smaller, smaller. That's what happens on contraction. So I have 200 cc's of volume in my ventricle, and the diameter, I'm making this up, 5 centimeters. But during contraction, the diameter goes down to 1 centimeter. Okay, so it went from 5, so size 5 would be like a size 10 dress, down to 1 centimeter, size 0 dress. Okay, so given volume in a size 10 dress, I put a size 10 volume in a size 10 dress, no pressure. But that size 10 dress rapidly shrinks to size 0, a lot of pressure. And that pressure is required because that's what opens the pulmonic valve on the right and the aortic valve on the left. So this is so incredibly important. But that pressure is really high and it pushes the tricuspid valve up into the atria and the mitral valve up into the atria. And basically that's happening at the same time. So tricuspid and mitral go up into the atria, causing a short pressure increase in the atria. Now, just remind yourself, especially if you work with cardiac patients, you remember that the valves are bound to thin, ropey cords that are embedded in muscle in the ventricular endothelium. That's called the papillary muscle. And it's really common with a big anterior MI, a big inferior MI, for you to actually infarct the papillary muscle. If you infarct the papillary muscle, the cord rips out. And so every time the ventricle contracts, and remember, it used to be either tricuspid or mitral, same pathophysiology, the valve bulges up into the atria, causing a short pressure increase in the atria. But now the valve bulges up into the atria and spurts blood into the atria. That's the regurgitating valve. So valve comes up into the atria and spurts blood up into the atria. That means the pressure in the atria is going to go up aggressively. And that's what you see when you have tricuspid regurg or you have mitral regurg. You're going to see the evidence of that in your venous pressures. And you're going to see that because you're going to know how to look at the V wave. The V wave actually is about valvular bulge. And if your valve regurgitates, the V wave is going to get really big. The A wave is about atrial contraction. And if your ventricle is stiff or you have tricuspid stenosis, your atria has to contract harder. So the A wave gets bigger. Oh my God, you said, maybe you knew, but most people say, I never knew that about the venous pressures. I'm not looking at A waves and V waves on my venous pressure and the CVP. And everybody here might not all take care of a patient with a PA catheter. Every one of you take care of patients with a central line. Every one of you. You should be looking at those waveforms because those waveforms are incredibly and profoundly telling about what's occurring for your patients. So that's all venous pressures. So now we're just going to look at the way the waveforms look. So A waves and V waves are typically very, very even. So typically you don't have much difference between the peak of the A and the peak of the V. And in between that, and this is spread out over time, is that little wave increase when the valve closes. Atrial contraction, closure of the valve, valvular bulge. Atrial contraction, closure of the valve, valvular bulge. Now on a strip chart recording, the peak of the A and the peak of the V should be just about the same. Here, your V wave is a little bit bigger. It's just an artist's rendition, and it was an artist who probably wasn't very well directed because the peak of the A and the peak of the V should be about the same. The C wave should be smaller. And a lot of times it's really discrete. I can hardly see it. Okay, so remember, A wave is the rise in pressure due to atrial contraction. C wave is the rise in pressure when the ventricle starts to contract and the valve closes, and that would be either tricuspid or mitral. It didn't say mitral there, and the V wave is the rise in pressure when the valve bulges upwards at the same time that the atria is filling with blood. Okay. Now, the X descent and the Y descent, those are much, much more related to looking at patients who have pneumo, hemo, cardiac tamponade. But X descent just means my atria contracted and it relaxed. The Y descent means the valve went up into the atria and now the atria is emptying. Okay, so this is relaxation after atrial contraction, and this is relaxation when the valve opens and the atria starts to empty. Now, on wedge pressure and on CVP, you will have at least two of these waveforms. You will always have an A wave and a V wave. On wedge pressure, sometimes you can't see the C wave. On CVP, usually you see the C wave because of the proximity to the right atria and the tricuspid valve. But remember, with wedge pressure, you're far away from the left heart. You might not see a pressure change with the C, but we don't really care about the C. You just need to know it's there. So you basically have three waves when you're looking at CVP: A wave, C wave, V wave, and generally two waves when you're looking at wedge: A wave and V wave. The bigger the A wave, the bigger the X descent. The bigger the V wave, the bigger the Y descent. Pretty straightforward. Very meaningful for us when we're looking at our pressures. So now, something that today in the CVICU, I encourage folks to remember that the only way you can know what wave is what, you cannot look at your monitor and say, oh, I see an A wave, C wave, and V wave. No, you cannot know that. It has to be correlated to the electrical event that caused it. So remember, CVP really close to the right heart, wedge pressure farther away from the left heart. So let's just talk right now about CVP. P wave causes atrial contraction. Atrial contraction causes an A wave. So in a dual channel, same time recording, you cannot do it by looking at your monitor. It has to be recorded in a two-channel recording. And you basically say, I'm going to line right where the P wave is. I'm going to draw a line straight down from my P wave, and it's going to intersect right there. And the wave following that intersection will be my A wave. I'm going to draw a line down from my T wave, about midpoint of the T, about midpoint of the T wave, and draw a line straight down, midpoint of the T wave, straight down. That's your V wave. Here's your A wave, here's your V wave. So what came in between was your C wave. Okay, it's pretty straightforward. Here's the problem. Your alarms go off all the time. So you use all your strip chart recording on your strip chart recorder. You use up all your paper with all these stacked alarms of patient after patient after patient. A lot of those alarms are nuisance alarms. I want to record. I go in the room. I go down to the bottom soft labels. I press recording. I say select real-time wave, and I'm going to select generally a lead 2 and the CVP pressure, or lead 2 and the wedge pressure. So I just want you to remember, this is really, really important. These waveforms are important because they tell us what's happening. Okay, so first and foremost, I want to remind you that venous pressure typically is small. So you need a small scale to look at that venous pressure. So sometimes you might walk into the room and you see a digital reading. Oh, the pressure in the central venous is 12, but I don't see any waveform. First thing you're going to do is make sure you have a scale that fits the pressure. Touch the waveform window, go to choose scale or optimize scale. That's probably the best, optimize scale. And the monitor will shift the scale to be appropriate for that pressure. Because here, my right atrial pressure, actually, you can see you got a little peak above 0 and then is below 0. Above 0 and then is below 0. So the average here, so let's just say that this is 1 above and 6 below. So the average pressure here is -5. -5. How did that happen? I'm not going to chart that. Let's move the transducer around. Something's wrong. I'm never going to chart that. Epic won't let me chart a negative pressure. I'm never telling the provider that it's a negative pressure. Okay, come on now, get a grip, right? Negative to 0 doesn't mean negative pressure. It means less than atmosphere. And I like to remind everybody that back in the old days, back in the old days when we put in catheters, venous catheters and PA catheters, they didn't have a one-way valve. So if you turned your stopcock the wrong way and your patient had a venous pressure like this, they would suck air into their tubing and get an air embolus. And that was really the #1 cause of death with central venous pressure monitoring. Now, we don't have that problem anymore. We have very developed central venous catheters with one-way valves that you can only open that valve if the fluid pressure at 300 millimeters of mercury through the transducer keeps that one-way valve open. And so very important for me to appreciate the way I get gas into my lung as I'm breathing here spontaneously is when the diaphragm descends, the pressure in the thoracic cage goes down, and it goes down less than atmosphere, and that sucks the air in. That's how I breathe. That down in the thoracic pressure is also communicated to your right ventricle. And really important to remember, you can indeed have a negative pressure in the right atrium. And there's only one thing that's happening here. As long as you're sure your equipment is right and you are level, you've got 300 millimeters of mercury in your pressure bag. There's no air in your tubing. So check your equipment. But then if all things are right with your equipment and your leveling, this is a patient, and there's only one answer here, profoundly hypovolemic. Okay, here's the time when CVP does tell you about volume. Now, everyone says to me, well, Epic won't let you chart a negative pressure. Why is Epic telling me what I can chart? It allows me to chart a CVP of 180 and give an SVR of negative 2,385. Why can't I chart a negative pressure? Mostly you can, but you have to understand it. And you have to be able to justify it. And you have to be able to say, when I zero reference my transducer, I'm looking at atmosphere, which here in Atlanta, 748 millimeters mercury. That means that any pressure my patient has either above 748 or below 748 is what gets inscribed on the monitor. So quite honestly, if I had a CVP of 6, that means that actually the pressure is 748 plus 6. No one wants to report a pressure of 754. So we just say, what's the pressure in relationship to 0? 0 is atmospheric pressure. That's really important for us to appreciate and understand, because without that, we can't understand what we're doing. So first and foremost, always make sure you have a scale that enables you to see the waveforms. The lower the CVP, the smaller the scale. The higher the CVP, the higher the scale. You need to have a scaled window that fits your waveforms. Okay. Now, when we talk about CVP and wedge, there are a couple of very important differences. CVP is almost direct to the RV. Wedge pressure is indirect to the LV. Okay, good. CVP has a direct relationship to the electrical events, but because the wedge pressure, that pressure column, is far from the left ventricle, there's a delay in the relationship of electrical events. In other words, the line I draw down post P communicates to the A wave in the central venous pressure. I'm going to have delay when I'm looking at wedge. So I still draw the line down post P, but I don't expect to see the A wave until just right after the QRS, because it takes time for that waveform to be conducted backwards. CVP is lower than wedge. Normal CVP, normal, is 0 to 8. And if you're on a ventilator, you're going to add 4 on either side, 4 to 12. Okay, that's normal central venous pressure. Normal wedge pressure, 8 to 12. And I'm going to add 2 to 4 to either side to say on positive pressure breathing. So wedge pressure is higher than CVP, and that's because I'm monitoring at the capillaries. Okay, and so I've got a long distance, plus the left atria has to generate a little more pressure on contraction, has to generate a little bit more pressure to fill the LV because the LV is a bigger muscle and less compliant. I can monitor CVP continuously or intermittently. If I'm needing to use that CVP, that distal lumen, the brown lumen on your central line, the blue lumen on your PA catheter, I want to monitor that continuously, but I might have to give medication through there. That's okay. So then that means that you're doing intermittent CVP monitoring, not continuous. If you're interrupting it to give medication, it's no longer continuous, it's intermittent. Wedge pressure is never anything but intermittent. If you are monitoring wedge pressure continuously, your patient is infarcting their pulmonary vascular bed. Do not do that. Do not allow yourself to be writing down a number that is reflective that your catheter, your PA catheter, has moved forward and is now in the occlusion position continuously. Your patient is infarcting their pulmonary vasculature. This is serious business. And one of the reasons that in the world today, depending on the units you work in and where you're working, that if you work in CVICU here at Grady, nurses are never allowed to inflate the balloon. Maybe some nurses with special privileges, myself, maybe others, but in general, you never inflate the balloon to get a wedge pressure. In the SICU, they inflate the balloon all the time. So it just depends on who your attending doctors are. But the problem is not so much that you inflate the balloon and leave it inflated. The problem is that as the catheter is residing in the patient, it's going to get softer, it stretches out, and the catheter tip moves into the pulmonary vasculature, into a pulmonary arterial, and into occlusion position. Anytime your PA catheter is in wedge for longer than 10 to 15 seconds, your patient is infarcting. And you might not have inflated the balloon, but the catheter is still stuck in wedge. Okay. All right, so CVP, remember, is a reflection of the volume and compliance of the right heart, right? We're measuring in the thoracic vena cava with a regular central catheter, but if it's with the PA catheter, we're measuring the right atrial. We call it CVP, but it's right atrial pressure. And essentially, they're the same because there's no valve between the vena cava and the right atria. So you're really monitoring one big chamber. That's your CVP. Everybody, if you got a central line, don't ask, you own that line. Connect it to monitoring. That's our policy. If there's an invasive line, connect it to monitoring. You don't have to ask your doctor if they want that information. They're just going to get it. That's all. Okay. So now we're going to just look now at that CVP pressure. And remember, line from the P, following that intersection in a dual channel recording is your A wave. Then I'm going to go over here to the midpoint of the T. I'm going to draw down, and there's your V wave. And from the V wave to the next A wave, this is all diastolic time. Here is the only time of systole, is right during that QRS. Okay. Now you'll see that I drew a line down here from my QRS where it intersected. I saw that C wave, which is basically the dichrotic notch of the venous pressure, reflecting that in CVP, your tricuspid valve is closed. Okay. Remember, in wedge, it will be the mitral valve closure. Okay. So really important to have some appreciation for the electrical events, P, Q, R, S, T, and the mechanical response of the atria, which is contract, fill, contract, fill. And we look at the A wave as atrial contraction. And while the atria is filling, the valve is bulging upwards. So that V wave is telling us about atrial filling. But quite honestly, the majority of the time, you're actually more concerned about the A wave. And hemodynamicists say, don't bother with everything else. It's really the A wave that's important. And you're going to look at the peak of the A wave because that's the optimal pressure that the atria generated to fill the ventricle. The less compliant the ventricle, the bigger the A wave is. The less compliant the valve, compliant, not regurgitant, stenotic. The less compliant the valve, the bigger the A wave. Oh my God, that's so incredible and so meaningful. So again, we just think about those relationships. So sorry about that. We just want to remind ourselves that CVP is a really good estimate or evaluation, RV preload, which is compliance and volume. Don't ever confuse central venous pressure with a volume indicator. It is not a volume indicator. It is primarily reflective of right ventricular compliance. So you can see this is a real patient. Drew the line down from his P wave. Here's his A wave. Drew a line down post T, and here's his V. Here's his A wave, and look, he has a big X descent. So the atria had to contract pretty hard, and then it relaxes significantly. And then here's my V wave. And you can see the A and V are almost the same. So that's a good thing, right? You look at the scale over here. The scale is embedded on the recording. It's also embedded on the monitor to the left of the waveform. You see the scale. And this scale is 0 to 30. Okay. So again, we just remember that CVP pressure normally 2 to 8, going to add 4 if you're on positive, or 0 to 8, either one is fine. And you're going to add 4 when you're on a positive pressure breathing. Okay, so very, very important for us to understand this relationship. So I want to just talk about patients on ventilators. Patients on ventilators, their inspiratory pressure is thrust upwards. So the higher level pressure is on taking a breath, and we always read on exhalation. So sometimes people say peak and valley. If you're breathing spontaneously, you're going to read it in the valley. If you're breathing spontaneously, you're going to read it at the peak. If you're breathing with positive pressure, you're going to read it at the valley. So what you're seeing here is positive pressure. Okay. All right. So now I've kind of embedded the relationship here, 0, 6, 12, and 18. That's our scale. You can see that your patient's pressure does drop below 0, especially when he takes a breath. And we can see if we draw a line down from our P wave, we draw a line down. Here's your A wave. And we draw a line down from, that's really should be just over a little bit from the T wave. Here's your V wave, and the wave in between is C. A, C, V, A, C, V, but we can't, that's kind of obliterated by breathing. A, C, and V. And when I'm looking at this, I'm saying to you that V wave is bigger than the A wave. Now, 4 millimeters, which is one little, 2 millimeter increase, which is 2 little boxes. If there's 2 boxes higher or higher than that, 3 boxes, 4 boxes, that's the millimeters as you count up and down. If they're greater than 2 millimeters difference, you might have valvular regurgitation here because the V wave is much bigger. Okay, so, here it is. Let's measure all values at end expiration. And so I want you now to look at our patient. Our patient has EKG, PA pressure, CVP, SATs, respiratory rate, and temperature, and non-invasive blood pressure. Okay, didn't have an A line, had a PA line, but didn't have an A line. Okay, now I'm looking at that right atrial pressure. So if I go in the room and the patient is not intubated and not receiving BiPAP, I'm going to remind myself that this is inspiratory, and therefore the pressure should be read up here. Okay. But if my patient's on Aprv or pressure control inverse, this will be all inspiratory pressure, and I need to read down here. So look at the difference. Here, the pressure is 0, and here, your pressure is around 17 or 18. Now, that's going to mean a lot to a person who really understands ventricular compliance. Okay, my ventricle, if I'm reading this as your exhalation time, then you have a CVP 17. But if I'm reading this as your exhalation time, your pressure is 0, your CVP, which would mean you got to have volume. Now, the problem is this is actually a patient who is on Aprv. So Aprv just means we have a constant high pressure that opens the alveoli. So it's like a high CPAP at around 25 to 30, high CPAP, and the right ventricle has to overcome that. And the right ventricle is a little weak guy, and he can't really overcome it. So if I'm saying that this is the true CVP pressure, and here you see it says RA because it's the PA catheter, so it's RA pressure. If this is the true RA pressure, your patient needs Flolan. Your patient needs nitric oxide. Your patient needs pulmonary dilation. You can't allow your patient to sit like this. There's something really wrong here, because this is not about volume. This is about compliance. So you could really make a difference in how patients do under your care if you are really focusing on evaluating waveforms and having a better idea about what's happening. In atrial fibrillation, because you don't have a consistent atrial contraction, your atria is just fibrillating, you're going to lose your A wave. You're not going to have an A wave, right? So that's kind of a hardship. Now you should have a V wave because your valve is closed most of the time, and just every once in a while the valve is open, and the atria is just fluctuating like this. So I'm going to see a lot of bouncy waves here, but I don't have anything valuable that I can call an A wave. So what I'm going to have to do in that case is I'm going to have to look at the V wave as the indicator of right ventricular filling. So you can see this is really important. This is all V wave here. All of it is V wave, and then the Y descent. Okay, tricuspid regurgitation. So here's what I love. I love it when I have a doc come in. I've got a central line. It's in the central vein. And the doctor says to me, that catheter's in the pulmonary artery. Oh, no, it's not. It's not long enough. A central line is not long enough to reach the pulmonary artery. Then they say that catheter's in the right ventricle. Well, it could be. But the probability is, if you take a look at this, you are regurgitating through your tricuspid valve. So remember, when your valve regurgitates, that's going to embed what we call a large V wave. This is actually where your A wave is. Very hard for you to see. You're not going to be able to see it because your regurgitation is so profound. So really big V waves occur when valves regurgitate, but the V wave is not about ventricular filling. It's about valvular disintegrity. So a large V wave on your CVP is telling you that you're regurgitating your tricuspid valve. So instead of blood going forward, it's going backwards. Okay. Now the way you make blood go forward is you dilate the forward chamber. So again, if I have a big V wave, my patient is unstable, doesn't have good blood pressure, doesn't have great urine output, but his lungs are completely dry, and I've got a V wave on my CVP, I'm asking the doc for some pulmonary dilation. So, if you're intubated, you can get nitric oxide or you can get Flolan. Not intubated, you can get nitroglycerin. Okay. Well, your patient's hypotensive. Oh my God, I can't do that. You understand the physiology. You've got an embedded V wave on your central line. You're regurgitating. Okay. Well, doc, okay, let's do this. How about if we do this? Let's do a POCUS, point of care ultrasound, or let's do an echo if we can get one. If we can't get an echo, let's do a POCUS. Look at your right atria, which will be huge because you're delivering blood back into the atria every time the ventricle contracts. And if my right atria is huge with an embedded V wave, I have to actually make the path for blood flow less resistance. And that's going to be the pulmonary vessels. So what I have to give you is something that dilates the pulmonary vessel. So, your choice, if you're not intubated, will be nitroglycerin, which is a very good pulmonary dilator, or milrinone, which is a pulmonary dilator and a mild inotrope. But really, truly, if you're otherwise stable, I would probably say just low dose. I mean low dose, like 10. Right? I'm not treating your blood pressure. I'm treating your pulmonary pulse. So I'd use a very low dose of nitro, and I do it very, very cautiously. So as I add nitro, and if it's working, that V wave is going to get smaller, smaller, smaller until my CVP looks more normal, because instead of blood going backwards, it's going forward. So that's really important. In tricuspid stenosis, look what happened to your A wave. Your A wave got really big because the atria is pushing hard, hard, hard to push blood through that narrow lumen, the stenotic valve. Your A wave also gets bigger, obviously, if your ventricle is hypertrophic or non-compliant. So I want to remind you, in the absence of tricuspid stenosis, the A wave, not your overall CVP, the A wave is the best reflector of ventricular compliance, the A wave, in the absence of valvular stenosis. Now, when your valve is stenotic, you're going to expect that A wave to be big. And that means that now look at your pressure in your CVP. I just told you it's not phasic. It looks phasic here. Big up, big down, big up, big down. But you should never see that in central venous pressure. You're seeing that in central venous pressure because either you have a big A wave or you have a big V wave. If you don't know how to look at waveforms, some percent of your patients, so in the CVICU, I'd say about 60% of your patients. In the emergency room, I'd say about 30% of your patients are being resuscitated incorrectly if you don't know how to look at the waveform. And remember, central venous pressure, we use everywhere. We use it no matter where you are. You can be in CV, SI, MICU, emergency room, 12A. We use central venous cannulas all over the place. We need to monitor them and we need to understand that waveform. Okay, so remember about the fact that any changes in intrathoracic pressure are going to affect your CVP. And we've really talked about that already. I just want to remind you on spontaneous breathing, here's your inspiration. So we always read on exhalation. So we're going to read the average up here, not down here. But with positive pressure ventilation, your inspiration is pushed upwards. So this is all inspiratory pressure, and we're going to read down there. Okay. So I read up here, spontaneous, and I read down here on positive pressure. Now, people talk about this as peaks and valleys. I don't really care if that's what helps you get through the night and monitor your patient. Well, fantastic. I personally find that to be kind of dismissive of understanding the physiology. When I put positive pressure into the thoracic cage, that pressure is transmitted to the ventricle. And that means that the pressure goes up during inspiration and falls during exhalation. And the opposite is true with spontaneous breathing. The only way I can get gas into the lung on spontaneous breathing is to generate negative inspiratory pressure with a diaphragmatic contraction, pull the floor of the cage down, makes the cage really big, and the pressure drops because now the cage is really compliant. Okay, lots of situations that occur with the RA. Whenever your pressure is low, it always means that you need volume. Whenever CVP is low, you need volume. If it's 0, if it's 1, if it's 2, if it's 4, or if it's -3, you need volume. It's only when CVP gets to the normal level or higher that you actually have to really evaluate what's happening with your patient. Things like what we've just talked about, tricuspid stenosis or regurg, RV failure, RV ischemia, pulmonary hypertension, which makes the RV hypertrophic, pulmonic valve stenosis, the RV is hypertrophic, and pulmonary embolism, and atrial dysrhythmias or AV conduction blocks, because now I've lost my A wave, but actually I'm going to have a lot more volume in the atria, and that's going to cause the right atrial pressure to go up. Okay, so last few minutes, I'm going to talk about pulmonary occlusion pressure, also known as wedge, PCW or PAOP, which is the correct term, pulmonary artery occlusion pressure. Indirectly reflects the left atrial pressure, and the left atria fills the left ventricle. So again, indirectly reflecting LV filling. Okay, so the only time I can measure wedge is if I have a PA catheter and the balloon is intermittently inflated, and the balloon should inflate and go into the wedge position with about 1.25 cc's of air. The syringe attached to that lumen of the PA catheter, from the CVICU or the MICU, the syringe attached to the red lumen, which is an air-containing unit, is in that syringe is pulled back to 1.5 cc's where it's locked, and you will slowly put the air into the balloon because you want that catheter to sail forward into the occlusion position. So look at your balloon is inflated and it's occluding everything from behind it. So in front of it, what you're looking at is the venous column of blood from capillary to vein to capillary to venule to vein to LA to LV. But it's also occluding. So you don't have any blood flow now. And that's why you never leave it inflated for more than 15 seconds. And then you've got to deflate. Because while the balloon's inflated, you're infarcting your pulmonary vasculature. And you don't want that to happen. So it's the intermittent development. So here's our normal PA pressure and our systemic arterial pressure and our CVP. And we're going to look at the correlates of the EKG. And then I inflate the balloon, which then gets me into the wedge visual. So see what that transition is from arterial to venous pressure. It's the only catheter you'll ever use, the only one that's ever been developed that can move from arterial pressure monitoring to venous pressure monitoring simply by inflating the balloon, allowing the catheter to sail forward, and from the very distal tip of the catheter looking forward at the venous column of blood as it transitions to the left atrium and left ventricle. Fantastic. But remember what I said before, So everything we talked about with venous pressure is exactly the same on wedge pressure as it is on CVP. You have an A wave, you have a C wave, you have a V wave, you have an X descent, you have a Y descent, but the timing is a little different. So I draw my line down from the QRS. Right away, I've got my A wave in CVP, but it's delayed for my wedge pressure. Okay, so that's really important. Wedge pressure, because it takes a little time for that to be reflected backwards all the way from my left atria to my pulmonary vein, to my pulmonary venule, to my pulmonary capillaries, to the distal tip of my PA catheter with the balloon inflated. And so you're going to see the A wave much sooner on CVP in direct correlation and a little bit delayed on wedge, but you're going to use the same basic dynamic here. You're going to draw that line down post P. You're going to expect to see the A wave immediately in CVP and just a little bit later in the wedge trace. And then you're going to draw a line down from the T wave. And again, immediately you're going to see the V wave, which remember is that valvular bulge. You're immediately going to see right after that intersection, you're going to see the V wave that reflects valvular bulge into the atria on your CVP, but the wedge is just a little bit delayed. So you can see it, this mechanical visualization occurs just a tad bit later on your wedge pressure. Okay, so here's a patient with a PA catheter. He has some unusual things on there, which we just don't have time to talk about, and it's okay. But I've inflated the balloon. So here's his PA pressure, which is around 50/20. And then I inflate the balloon. The catheter sails forward into an occlusion position, and I am now reading the wedge pressure at around 15. Okay, so my wedge pressure is lower than my PAD, which is 20. My wedge pressure is around 15. Okay, so by the way, on insertion of the PA catheter, if you're the bedside nurse who's working with the physician on insertion, you're monitoring all those pressures as the catheter goes in. You need to record them because you're not going to have time to write that down, but you need to know that the PAD is 5 or less higher than the wedge pressure, 5 or less higher. I no longer need to inflate my balloon, and I'm just going to use PAD. If the PAD is significantly higher, more than 5 higher than wedge pressure, I cannot use PAD to reflect left heart. I can't, and I should not, and I won't agree to it. I'm sorry. I'm sorry. If you want to know about the left heart, you need to come in and wedge the catheter, or you've got to give me permission to do so, one or the other. That's it. I'm not going to use PAD to reflect LV filling because the gradient is too high. That happens when you have pulmonary hypertension, but normal LV filling. So when you have pulmonary hypertension, you're going to expect that PA diastolic to be higher and the wedge to be normal. But the gradient is profoundly important in terms of how we look at our patients. So here's your PA pressure. And we already looked at wedge. So just like with the tricuspid, just like the venous pressure on the right heart, CVP, and just like talking about the tricuspid valve with CVP, we're going to apply the same thing to the mitral valve. The mitral valve is stenotic or regurgitant. Mitral valve stenotic, you expect a big A. If the mitral valve is regurgitant, you expect a big V. The problem here is that when you're inserting the PA catheter, sometimes it's really hard to tell that you're in wedge because the A wave is really big or the V wave is really big, and you didn't really think that your catheter sailed into the wedge position. That's really important. Same kinds of things. LV infarct, LV ischemia, LV failure, dissociation, same as what you talked about on the right heart side, just remembering that there's a delay in the transmission of the waveforms and that the wedge pressure is very indirect for looking at left heart, okay? So I just want to remind you that the biggest effector of venous pressure changes, apart from the usual suspects, which are things like stenotic valve and failure, number one is increased heart rate. As the heart beats faster, so at the heart beats at 60, it's eject, fill, eject, fill, eject, fill. But as the heart beats faster, no time to fill, the ventricular chamber is more narrow, and your venous pressure goes up. Number one, tachycardia will make your CVP and your wedge pressure elevate. But it's from the tachycardia, it's not necessarily because patient has ventricular incompetence. Okay. The second biggest effector that's not a usual suspect is positive pressure breathing. So lots of these patients who have PA catheters, not all of them, are intubated on a ventilator. So you got to really consider that. You're downstairs in the ECC or in 12A or 5J or some other place. Your patient has positive pressure with a BiPAP, or they're intubated on a ventilator. CVP is going to be elevated. That's elevated because of the positive pressure, but it's not necessarily ventricular discompetence. So really, really, really important. RA pressure, CVP, and wedge pressure are both elevated in tamponade, constrictive pericarditis, and in profound volume overload. They'll both be elevated. But in cardiac tamponade, so really important for people taking care of cardiac surgical patients, RA and CVP, RA and wedge pressure are equally elevated. They don't look any different from the other. In tamponade, because now you have one big dysfunctional chamber. So that's one of the most telling signs of cardiac tamponade that we can see. We're monitoring RA, we're monitoring PA pressure, and what we see is that our CVP or RA pressure equals the PA diastolic pressure. You ask one of your APPs to come in, inflate the balloon, and your CVP and your RA and your wedge pressure are the same. They're exactly the same. You can't tell the difference. Now remember, RA pressure should always be lower than wedge pressure, but now wedge pressure and RA are both elevated and they are equally elevated. That is a diagnostic sign for cardiac tamponade. So here's the thing. We're looking at a PA pressure and a wedge pressure. Here's your A wave and your V wave, okay? Here you can see that you have a very large V wave here. So in the PA, what you see is PA systole and V wave, PA systole and V wave, and you inflate your balloon and the PA systole disappears, but you still have a V wave. Most common problem with interpretation of failure to float a PA catheter into the wedge position is a regurgitating mitral valve, which instills a large V wave, which unless you really look at what you're doing, you won't actually recognize the difference between the PA pressure and the regurgitating pressure. Okay, so here again is a large V wave on your wedge pressure. That's in your LA. This is a large V wave. So most of the time you would look at that and you say, oh, that's PA pressure, that's arterial or ventricular. No, it's not. It's the V wave of mitral regurg. And this is also a cath lab visual, large V wave here of mitral regurg. That's probably the most common problem with wedge pressures. So understanding venous pressure, understanding the components, A wave on atrial contraction, C wave on closure of the valve, V wave on bulge upward of the valve when you're in ventricular contraction and the atria is filling at the same time. The concepts are exactly the same for right heart and left heart. We separate them because you can have right heart problems, but not left heart. You can have left heart problems, but not right heart. And that's why if you're lucky to have a PA catheter, you're going to do CVP or RA plus wedge. If all you have is a central line, you need to really look at that CVP and really understand the waveform analysis. And just to remind you, CVP is almost a direct evaluation of the RV. Wedge pressure is indirect for the LV, and PAD is even more indirect. It's okay. I mean, it's just indirect. So CVP is directly related to the electrical event, but we have a delayed visualization in response to the electrical event in the wedge pressure because that catheter is farther away from the left atria and the left ventricle. CVP is typically lower than wedge pressure. CVP is lower. Normal CVP, remember, 0 to 8, and normal wedge pressure is 8 to 12. So wedge pressure is supposed to be higher than CVP. CVP can be measured continuously or intermittently. You'd like to measure it continuously, but if it's your only lumen, everything else has been used up and it's the only lumen you have left, then you're going to use that CVP lumen on your central line, and on your PA catheter, you're going to use your RA lumen. That's the blue lumen. That's the PA, but it's called proximal injectate. It doesn't say CVP or RA, but it's blue. So the blue lumen, you monitor continuously, and you only monitor it intermittently if you have no other choice for where you're giving medication, okay? Wedge pressure is intermittent only. Never leave the balloon inflated for more than 15 seconds, but also remember that as the patient gets better and his blood flow improves, the catheter is going to move especially if you have a big loop in the ventricle, the catheter is going to move into the wedge position. The catheter is also a rubber, and that rubber basically it's not really rubber, it's silicone, but it gets soft inside the human body, so that catheter then extends. If you walk into the room and you see something that no longer looks phasic, big systole, dicrotic notch, and diastole, but kind of these vacillating waveforms, first thing you do is make sure there's no air bubbles in the system. Second thing you do is make sure your pressure bag is at 300 millimeters of mercury. Flush, flush, flush. And not manually, only with your little pigtail, because you won't be able to flush much solution. And if that doesn't clear, you need to call a provider and say, my catheter is stuck in wedge. Now, what they're going to say to you if you're using a PA catheter, well, deflate the balloon. No, the balloon's not inflated. Thank you. Thank you so much. The balloon's not inflated. The catheter is just migrated forward, and it often does that actually as patients improve. So as their blood flow gets better, the catheter moves forward, especially if you have a fairly large loop. And you'll hear people say, oh, he's got a large loop in the RV. Well, then just anticipate catheter's going to get stuck in wedge. I'll be right there.
Okay.
That's my husband. So I'm picking up my grandbaby tonight, so he's here to get me. So the conclusions are to remember, hemodynamics are a window into heart physiology. Venous pressure is used to tell you about ventricular filling. Systolic pressure is reflected in ventricular ejection. To fill the right ventricle, you're going to monitor CVP or RA, and to monitor right ventricular ejection, the only way you can do that is with a PA catheter looking at PA systole. For your left ventricle, systemic systolic pressure reflects LV ejection, but the only way you can absolutely look at LV filling is with a PA catheter. And just remember, the purpose of the PA catheter is to allow us visualization of the ejection of the right heart and indirectly the filling of the left heart. So this was a very intense talk, but so fantastic that you all were here, that you stayed on. Really, really, really significantly and profoundly important. And really meaningful for us to be looking at the values that we actually monitor every day. No matter where we work, we're looking at CVP pressures. And if we're not, we should be. And we should be looking at CVP waveforms. But remember, you can only evaluate the waveform in a 2-channel recording with EKG and CVP. Same will be true for wedge pressure. When you have arterial pressure, it's pretty easy to figure out. The biggest up is systole and the lowest low is diastole. But with venous pressure, you've got to identify at least your A wave and your V wave, and you can't do that unless you can do a dual channel recording, because you can't do it on the monitor. So we need to be sure that we have that capability available, that we're using it well. And I hope that you feel like you can take this knowledge forward to actually better evaluate and manage your patients, to promote better care, to communicate more effectively with your colleagues. And I thank you very, very much for joining me here today. Thank you. And I'm going to see you tomorrow or next week. So.